All right, I guess we're gonna start and then let everyone else join a bit later. Hello, everyone. It's my great pleasure to introduce our speaker for today's webinar, Tamara Stambuk. Tamara is a senior researcher at Genos Glycoscience Research Laboratory. She's an expert in the field of glycobiology. She has a master's degree in pharmacy and a PhD in biochemistry and brings a wealth of knowledge and expertise to the table. Tamara's research focuses on the use of glycans as biomarkers in all sorts of areas. Her work has the potential to transform the way we diagnose and treat diseases. I'm sure you'll find her insight and expertise both enlightening and inspiring. Without further ado, I would like to hand over to Tamara for her presentation. And we'll have a Q&A session after the presentation, so feel free to drop your questions in the chat and we'll address them after. Thank you.
Thank you, Zori, for this very kind introduction. A very good afternoon to everyone and welcome to the Glycan Age educational webinar series. So today we're talking about the role of glycosylation in cardiovascular disease. And I'm sure that, okay, my slides aren't moving. Okay. And I'm sure that when we're talking about cardiovascular disease, most of us think of heart disease and stroke immediately. And in general terms, we can say that the cardiovascular diseases are a group of disorders of the heart and blood vessels. But as you can see from this cartoon here, this is a very heterogeneous group of disorders, and it affects many organs in our body. And the underlying cause of the majority of these disorders is the endothelial dysfunction. So endothelium is the type of cells which line the entire vascular system. And endothelial function is important for the health of our cardiovascular system. Well, as endothelial dysfunction occurs, it represents a systemic disease. And it can be defined as the precursor and earliest clinically detectable form of atherosclerosis. And I'm sure we all heard of atherosclerosis, and it's a condition where the wall of our arteries develops abnormalities, which are usually called lesions in the early phase. And they're characterized by buildup of fats, cholesterol, calcium, and other substances which are usually present in our blood. But then they build up in and on the artery walls. And this buildup is usually called plaque, and plaque can cause arteries to narrow, blocking blood flow, but it can also rupture, leading to the formation of the blood clots and thrombosis, which can be fatal sometimes. And this brings me to these unlucky statistics that nowadays cardiovascular diseases are still the #1 killer globally. Translating to numbers, the cardiovascular diseases are responsible for 1/3 of all annual global deaths. And in numbers, this would mean that nearly 20 million people die of cardiovascular diseases each year. Here, I wanted to list some common risk factors for the development of cardiovascular diseases, which majority of them are linked to the nowadays modern sedentary lifestyle, including physical inactivity, unhealthy diet, harmful use of alcohol and tobacco, overweight and obesity, high cholesterol and high blood pressure, and associated comorbidities such as diabetes and kidney disease. What is important to highlight is that the majority of these risk factors are modifiable and we can have our influence on them. In first line, I'm talking about unhealthy diet and physical inactivity, which are the major causes of obesity, type 2 diabetes, and cardiovascular disease. And this brings me to another sad statistics, and these are the estimates that 1/3 of world's population nowadays is overweight and obese, which is pretty shocking, I would say. But what's even more worrisome is the fact that even young children are becoming obese and overweight, and there's an estimate that nearly 40 million children under the age of 5 years are nowadays overweight. So we should definitely take some action to prevent that. And what can we do to prevent cardiovascular diseases? Firstly, lead an active lifestyle. So here we're not talking about some intense exercise regime. We're talking only about 150 minutes per week or 30 minutes a day of a moderate intensity activity, which can reduce the risk of type 2 diabetes and cardiovascular disease up to 35%. And also, exercise helps to keep our hormones in balance. Next, we should eat light and balanced meal. And by this, I mean we should prioritize foods as vegetables, fruits, fish, low-fat dairy products, and whole grains, which are rich in fiber, and eat fresh as much as possible. But also we should avoid salt and sugar and trans fats and processed food. Then we should also keep in line our waist circumference, our blood pressure, and our cholesterol, because having an increased waist circumference can raise your risk of type 2 diabetes and heart disease, and high blood sugar or high blood pressure also. But you can keep your blood pressure in line by limiting your sodium intake and by increasing potassium intake and drinking alcohol in moderation. And also, I would like to highlight here that the lipids are important, but if their levels are too high, they increase the risk of type 2 diabetes and heart diseases. And this brings me to the glycosylation. So this is the major focus of our research here in Zagreb. And glycosylation we're dealing with is a post-translational modification of proteins. And opposed to proteins whose polypeptide backbone is encoded in DNA, glycans do not have a direct genetic template. Oppositely, we consider them as an integrators of genetic information and epigenetic and environmental influences. And since glycan composition is very susceptible to various cellular stimuli, they have a huge potential as the biomarkers of different pathophysiological conditions. And also, what I would like to stress here is the fact that glycosylation often gets mixed up with glycation, but these are not the same processes. So as I already mentioned, glycosylation is a highly regulated and controlled process which is enzymatically mediated, and it denotes the attachment of a complex sugar molecules to the proteins. And this attachment enriches protein function, and it increases their stability and then enriches their structure. But on the other hand, glycation is a random, not controlled process. It's not enzymatically mediated. It just denotes the attachment of simple sugars such as glucose or galactose on the random spots on the protein, and this damages protein function. So as I already mentioned, glycosylation is involved in nearly every process in our body. And of course, it plays a role in cardiovascular disease development as well. And recent studies have detected that glycan biosynthetic pathways are altered in cardiovascular diseases, and glycan alterations have been described in cardiac hypertrophy, heart failure, myocardial ischemia, hypertension, arrhythmias, aortic valve stenosis, etc., etc. And also, glycan alterations impact receptor, peptide, hormones, and ion channel stability and activity. So glycosylation has a significant biomarker and therapy potential in the field of cardiovascular diseases. And I would like to introduce you to one of our first studies concerning this topic. It was the study on the glycan composition of LDL and HDL particles. So as you're all pretty aware of, the causal link between levels of low-density lipoprotein cholesterol and the risk of cardiovascular diseases, including myocardial infarction, has been known for quite some time now. and also the low level of the HDL or high-density lipoprotein, which is considered like a good cholesterol, have been consistently associated with increased risk of cardiometabolic disorders. So the major structural components regarding the protein compartment of these particles are plasma lipoproteins, and they are in fact glycoproteins, and they carry multiple and various glycan structures, but their composition and functional importance is still undetermined. And what we've done here, we profiled the N-glycom of the entire particles, so not the individual glycoproteins, but of the entire particles. And as you can see from the chromatograms here, they differ greatly between each other, both in the structures which are represented and in their ratios. But what is maybe more important to highlight here is if you modify these glycans, the function of the particles also gets impacted. For instance, if you use this enzyme called neuraminidase, which cleaves the terminal sialic acids from the glycans, and if you do decellulation of the LDL particle, then the cellular accumulation of cholesterol esters in the receiving cells significantly increases after the decellulation. And you can say, in other words, if you decellulate LDL particles, you kind of even more increase its activity. On the other hand, if you decellulate HDL cholesterol, this would significantly decrease its efficacy in removing cellular cholesterol from the receiving macrophagic cells when compared to the native sialylated HDL cholesterol. In simpler terms, you can say that if you decellulate HDL, then you would decrease its activity. So glycans clearly play a significant role in their function. We also investigated a role of IgG glycosylation in dyslipidemias. And dyslipidemia can be defined as the imbalance of lipids such as cholesterol, low-density lipoproteins, triglycerides, and high-density lipoproteins. And here we found out that the glycan structure originating from antibody immunoglobulin G, which carry this bisecting glucanac and which are not fully galactosylated, positively correlate with elevated blood lipid levels. And on the other hand, glycan structure which are fully galactosylated and which carry sialic acid are negatively correlated with dyslipidemia. Then there are several mouse model studies which investigate the glycan role in the induction of obesity-related hypertension. So what was shown and investigated here, that non-sialylated IgG, so again, sialic acid is clearly important in cardiovascular diseases. So non-sialylated IgG binds with enhanced affinity to its endothelial receptor Fc gamma 2b, and this increased binding is somehow affecting these vascular endothelial growth factor signaling pathways, which has a consequence the diminished production of the nitrite oxide. Nitrite oxide is a very potent vasodilatory molecule, and it has direct impact on the vasomotor tone. So if you decrease its production, you would have increased vasomotor tone, which clearly causes hypertension. On the other hand, if you have a fully sialylated IgG glycan, then the IgG still binds to the receptor, but not with such enhanced affinity, and this signaling remains preserved, and the NO production remains preserved. So there's no induction of the hypertension. What was even more interesting here is the fact that so they had a couple of groups of mice. They had a control group of mice, which was fed with normal chow. And then they had two groups of high-fat diet-fed mice, and one group was supplemented with this MANAC, molecule, which is a cellular precursor in the biosynthetic pathway of the sialic acid. So one group was fed with sialic acid, and other with sialic acid precursor, and the other wasn't. So both groups gained weight as they were on the high-fat diet, but the one which was supplemented with the sialic acid precursor had a normal levels of IgG cellulation when compared to the group which wasn't supplemented. And what was interesting, that these blue group mice were gaining weight, so they were getting fat, but they did not develop hypertension. So cellulation of their IgG prevented them from developing hypertension. And on the other hand, those mice who were not supplemented with MANAC developed hypertension. Also, there was another study about the role of this endothelial Fc gamma 2b receptor and the immunoglobulin G. And they shown that the serum IgG levels and the expression of the receptor are increased in both hypertensive mice and people. And further mechanistic studies have revealed that IgG somehow stimulates the Fc gamma 2b association with another receptor, and this is a receptor for the angiotensin 2, which is a non-player in the regulation of the vasomotor tone. And this increased binding has a downstream consequence of increased contraction, hypertrophy, and fibrosis of the smooth muscle cells, which also causes hypertension. On the other hand, if you would block this binding of IgG to its receptor, then you would block also or lower the angiotensin 2 mediated signaling, and you would prevent the induction of hypertension. So clearly, IgG has a major role on the cellular level when it comes to the development of hypertension. So these were all studies done on mice, so we still don't have the confirmation in human, but what the human studies have shown us that the glycosylation of immunoglobulin G correlates with incident hypertension. And here again, as you can see, the major players are the glycans, which do not carry galactose residues or only have one galactose residues, and which carry this bisecting glucanac, so this square in the middle. And they are positively correlated with incident hypertension. And again, on the other hand, glycans which carry sialic acid are negatively correlated, or in other terms, you can say that they have some kind of protective role. And also, we have cross-sectionally examined IgG glycan composition in various studies related to hypertension. And what we see here is that in several cohorts, you have healthy controls, you have people with pre-hypertension and with hypertension. And as you can see, you have the gradual increase in this non-galactosylated structure as the diagnosis of hypertension approaches, and conversely, you have a gradual decrease in this fully galactosylated and glycan structure. Then we did another study regarding IgG glycosylation, which assess the role of IgG glycans on traditional risk factor for cardiovascular diseases and on presence of subclinical atherosclerosis. And what we've done here, we profiled immunoglobulin G and glycosylation in nearly 3,000 women from the Twins UK Biobank, and correlated it to their estimated 10-year atherosclerotic cardiovascular disease risk score, and with their carotid and femoral plaque measured by ultrasound imaging. And what we saw here was similar as we did before. So the glycans originating from IgG with bisecting glucanac are positively associated with the presence of the atherosclerotic plaque. And the glycans, which are fully galactosylated and sialylated, are again negatively correlated. And this was also replicated in another independent population, which comprised nearly 1,000 women from the ORCIDES cohort. What we've seen also in this study was that if you construct a glycan-based score for the prediction of cardiovascular disease development, it nicely correlates with the traditionally used AHA risk score, and the risk score is consistently higher in the participants which already present with a carotid or femoral plaque. And what also popped out was this singly sialylated, monosialylated glycan structure from the FC portion of immunoglobulin G, which was significantly lowered in people who already have a subclinically present atherosclerosis. And this sialylated glycan structure was negatively correlated with the very low density lipoprotein levels. And very low density lipoproteins are the major players in the development of atherosclerosis. So once again, sialylation has proven itself as a very important in the development of cardiovascular diseases. And since our previous studies have shown a significant association between immunoglobulin G and glycosylation and the development of atherosclerotic plaques, we wanted to investigate whether we can see some changes in already developed and overt disease. In this case, it was a coronary artery disease. And we performed a sex stratified analysis. And what we saw here is that in women, IgG sialylation is significantly lowered in participants who are affected by the coronary artery disease, but this difference was not as pronounced in men. And also, these levels of bisecting glycans are increased in both women and men with the overt disease. Then, in line with the immunoglobulin G glycosylation, we also wanted to explore if plasma protein and glycans can serve as a risk markers of future cardiovascular events. And for this purpose, we profiled glycans in baseline healthy participants from the EPIC POSDEM study. There were like 3,500 of them. So they were all healthy at the time of sampling, and they were monitored for multiple years. And around 400 developed some major cardiovascular events, including myocardial infarction and stroke. And we also performed sex stratified analysis. And what we saw here is that opposed to the popular belief, when it comes to the cardiovascular disease and glycosylation, men are far more complicated than the women. And we constructed this risk score for men, which included these 7 glycan structures originating from plasma glycoproteins. And then we tried to predict who of the baseline healthy men would develop some major cardiovascular event. And our predictive performance was not very successful. It was moderate, but it was still comparable to the usually clinically used AHA score. In women, the same was done, but with this single glycan structure. So this monogalactosylated corticosylated glycan structure. And what we saw here is if we use the structure and the age of the participants, we can rather successfully predict the future cardiovascular events in women. And if you combine the clinically used score and our score, then you would get even better prediction, which kind of implies that the glycan carry additional clinically valuable information beyond the traditionally used risk factors. And then we've done practically the same thing on the same study population, but this time we profiled immunoglobulin G and glycans. and check their performance as risk markers of future cardiovascular events. And as you can see here, men are, again, more complicated than the women. In women, the best and the most informative was this single N-glycan structure, which is practically the same glycan as it was in the previous case when we explored plasma N-glycan. And it has a protective role. So this would mean the higher the glycan, the less you're likely to develop cardiovascular event. In men, we had constructed this IgG and glycan-based risk score comprising these two glycan structures and evaluated its performance in several models. What this model usually tell us is in each of the model, we've included some of the traditionally used clinical risk factors. And the glycan-based risk score in men and this GP9 in women still remains significant after you take into account all of the clinically used risk factors such as age, education level, alcohol intake, physical activity, BMI, waist circumference, hypertension, and hypertensive lipid-lowering drug use, kidney function measures, total cholesterol, and HDL, and CRP, which is a marker of inflammation, and HbA1c, so practically all of the clinically relevant risk markers. And this clearly shows that the glycan do carry relevant information that surpasses the traditional risk markers. I wanted just to show you that things are not so simple and linear. And in addition to the glycans I've shown before, there are still several markers several glycans which are still significantly associated with cardiovascular events, but which do not have these linear associations with the risk, but are non-linear. So I won't go into any details, but as you can see, things get way more complicated. And this brings me to my last slide, basically, where I would like to once again highlight the fact that glycans are both directly and indirectly associated with cardiovascular diseases. As I've shown you in a couple of examples, glycans are associated with cardiovascular disease risk factors, and also glycans impact both hormone, ion channel, immune cell, lipoprotein, endothelial cell, immunoglobulin receptor, and plasma protein structure stability and their function. And with this, I would like to thank you all for your attention. And if you have any questions, feel free to ask. Thank you.
Thank you, Tamara, for this lovely presentation as well. Does anyone have any questions or perhaps would like to share experience and any observation in their practice of what they've observed with regards to this?
I have a question. What's the difference between glycation and glycosylation?
Okay. Should I return to my slide?
Yes, I didn't really understand the difference, and you know, isn't it just sugar molecules binding to proteins? Isn't that?
Oh, okay.
The long and short.
Let me just find another example. Okay, so you see here, this is the way we depict our glycans, and it is small squares, circles, etc. This is a single sugar molecule, and they're bound in a very complicated way. And our glycan usually contains at least 14 single sugar molecules. So it's an oligosaccharide. It's not just galactose, just glucose, just an acetylglucosamine. So it's a complex molecule. And then When you look at glycation, you have the attachment of a single sugar molecule. So you have attachment of the glucose or the galactose or the fructose, but the glucose is the major one, which gets attached to the protein. And this happens randomly. So you don't have a defined spot where glycation occurs. And this usually causes damage to the protein function and stability. Glycation has a preserved site where so glycans get attached.
Wait a minute. You mean glycosylation? You said glycation. You mean glycosylation is a much larger sugar molecule and it
Yes.
only goes into a receptor. Is that correct?
So glycosylation gets at exactly the defined spot at the protein backbone. So you have to have this conserved sequence of 3 amino acids to get a glycan attached to the protein. And this is highly and strictly regulated and is enzymatically mediated. And glycation is not enzymatically mediated process. So it's a random process, and it usually occurs in the states of high blood sugar levels, such as diabetes.
Okay. Okay. And so then with glycosylation,
Okay.
you are, and then you were trying to mediate glycosylation with an enzyme, and because you were claiming glycosylation caused heart disease or prevented heart disease. I'm a little confused about.
Okay, so glycosylation is a naturally occurring process, and it happens in all of our cells. And all major portion of our proteins are glycosylated. So what we're actually looking at in majority of cases is how this glycosylation changes in certain diseases on certain proteins. And vast majority of our studies includes immunoglobulin G, so the dominant antibody in our bloodstream. Okay, so we're not affecting the glycosylation in any way. So we're not doing any kind of cell culture or anything. We're just looking how disease impacts glycan patterns of a single glycoprotein. Is this a bit clear now?
Okay. So glycosylation is not you pre-making a chemical, pre-making a sugar, a complex sugar, and putting it in the body.
No,
this is the body is making the complex sugars.
Yes,
they're attaching to IgG.
Yeah, glycosylation is a post-translational modification of a protein. So this is the naturally occurring process when your protein gets transcribed from the RNA. So when your protein is synthesized within your cell, some majority of proteins get their glycans attached. So this is a natural process.
And that's the glycosylation.
Glycosylation, yes.
Okay. And then, so these glycosylated proteins, and it's the same complex sugar every time, or are there different ones that make the proteins behave differently?
So I have an example here. So they're different. So one protein can carry many different sugars, not at the same time. So you have hundreds of proteins. Each of them can have a different sugar molecules. So they have the same function in the body, but this function gets fine-tuned with depending on the glycan which is attached to it. Okay.
Okay, and what mediates this process of glycosylation of proteins?
Okay, so then we get back to this slide. So you have both genetics, which influence the glycans which are attached on your proteins, but you get different cellular stimuli, such as epigenetics and environmental influences. So the glycans, the composition of glycan which will be attached to a protein is kind of an integration of all these stimuli that your cell receives at the time the glycoprotein is being synthesized.
Okay. Okay, so would a low sugar diet affect glycosylation, or a low carbohydrate diet?
It would to some extent. So we've done some studies when we looked at the total plasma and glycom, and what we saw there is if you have a very low calorie diet, so it wasn't carbohydrate restricted, but just very low calorie, your end glycom changes. So your end glycom.
Okay, it changes, but does it change for the better or for the worse?
We don't know, because the exact causal link between these changes and the development of the diseases is still not established. So this is what we're trying to figure out, basically.
Okay, because there is advocacy in the Alzheimer's community and epilepsy communities to go to a high-fat diet and minimize carbohydrates because of the problems they have crossing the blood-brain barrier and even possibly blocking passages in the blood-brain barrier. And so in that case, you would reduce or change your glycosylation and glycation itself, right?
Yeah, you would expect to, yeah.
I mean, I even have a friend who has and he may be listening, who has a drug that is a anti-glycation drug. In other words, it breaks the glycation bonds, one type of glycation bond. And so you have less stiff cartilage, less stiff heart muscle, less stiff arteries because of his pill.
Okay.
Because it's an anti-glycation pill. But obviously if you eat a low carbohydrate diet, you avoid glycation also. Right, but that's different. But would that also mean that you would have reduced glycosylation, which, as you said, it's not as random. It's not as random as glycation. But
so our cells can produce these sugar molecules, which are the major structural components of the glycans. So they are not as dependent on the outsources, so on the exogenous sources. So you can influence by your diet to some extent. So if you're on the, let's say, if you're on the opposite side, so if you have a very, very, very high carbohydrate intake, and then you would surplus your sugar donor production, and this could lead, for example, if you look at your plasma glycoproteins, they would be more complex, more branched, they would contain more sugar residues. But then if you would reduce your carbohydrate levels, these structures would fall for a bit, but would not vanish completely. So your cell still has the resources to build the sugars which it needs. So if I'm making any sense now. So you would to some extent, but not so that you would diminish the production completely. So the glycans are essential for normal cell functioning, and they're normally produced within the cells. Okay, and so they're not dependent on the exogenous sources and on the nutrition.
Of sugars, of simple sugars.
Simple sugars.
Okay.
Yeah.
Okay, that's impressive. That's impressive that the cells can make have their own non-essential sugars, I guess, just as there are non-essential amino acids and non-essential fats. So that's impressive. And so is all the glycosylation coming from cell-generated sugars? I think you were saying it is, correct?
Yes. So all the stuff we're looking at are actually mirroring the cell state at the time this glycoprotein was produced.
Wow, impressive. So it's really mediated by the cell itself. What glycosylation happens.
Yes. This is like in the same category as the protein synthesis, so it's the same.
Okay. And you guys are trying to modify this. Well, I think what you were saying is cardiovascular disease is caused by glycosylation of proteins?
No, it's not caused. We see some changes of glycosylation which are associated to cardiovascular diseases, And we're trying to understand whether these glycan changes are the cause or the consequence of the, so do they have a biomarker potential, or if they're causative, can we change them by some certain therapies? And this is the everlasting question. So it's the question in our community for the past 2 or 3 decades. So nobody still hasn't elucidated. Is it the cause or the consequences or the consequence of the disease?
Interesting. So my friend's drug that breaks glycation bonds would not break glycosylation bonds, perhaps.
No, it would not, certainly.
Okay. Okay. I'm impressed with this drug because it makes me stronger. When I go to lift weights, I can lift like 20% more weights when I take this drug. It's a weird drug.
Yeah, it's impressive. Okay.
Sorry, but then do you see the patterns of glycosylation change if there are any lifestyle interventions? So, if someone is supposed to be at high risk for cardiovascular disease because they have diabetes, they're obese, you put them on a diet, the blood pressure goes down. Do you see any change in the glycosylation patterns if you retest them?
So we do not have the follow-up of the same people. We have a limited number of intervention studies. What we've seen so far is that certain diets, such as very low-calorie diet, impact the glycosylation, and in general, you can say that they improve glycosylation. Although I'm not supposed to say improve, but the changes go in the favorable direction, let's say, call it like that. But we are still at the beginning with these intervention studies, and you have to monitor people for a very long time. So these prospective cohorts we were looking at here, I was mentioning Twins UK and EPIC Potsdam study. So the people were monitored for 10 and plus years. So this is a very, very long-term goal.
I see. So it takes that long to see any kind of change in these patterns.
It would change if you're measuring the efficacy of any interventions in your practice for your patients. You should be able to see changes within 3 to 6 months. Usually, changes within 6 months would appear. So if you test them before a specific intervention, as you said, you put them on a diet, and you test them after 6 months, you would be able to see the glycan structures change within those 6 months, and you would be able to evaluate if this intervention is working in a positive or a negative way. So yes, this is possible, and it's what we observe with all our partners. So they use the test to measure the efficacy of their interventions within their practice by measuring before and after the specific interventions that they have. But we don't have studies on all of these interventions to prove that some studies definitely work. Yet partners do use it as a measuring tool to verify their own interventions.
Okay, I got it. Thank you.
So I would just like to say once again, so you see the glycosylation changes, as Zori said, but if you would like to monitor long-term outcomes such as major cardiovascular events, then you would have to follow up your patient or your patient for a very long time. So you would not expect them to develop major cardiovascular events in short terms. So this is, but you see the glycosylation changes in a couple of months.
Okay, thank you.
Thank you, Olivia. We do have some more questions in the chat as well. I don't know if you would be able to have a look, Tamara.
Okay, so I have the first. Can we reuse glycan age test results for CVD risk directly? Glycan age measures certain glycans which were associated with cardiovascular disease risk, but I wouldn't say we can assess the risk directly. I mean, you can get a glimpse of maybe if you're in the higher end or the lower end of the population and the spread of the glycan feature. in the abundance of the glycan features. So you can say, okay, you're in the first quartile, and this glycan was associated with a higher risk. But you cannot define, okay, you have a 13% more chances than the general population. So it's not in this way. Okay, then what's the sample preparation that was used to extract analytes and the analytical method for analysis? So the majority of studies I've presented here are based on the chromatographic approaches. So what we do, we enzymatically cleave N-glycans from the glycoproteins, and then we fluorescently label them, and then we analyze them using liquid chromatography, and then you get these glycan peaks. You integrate your chromatogram, and then you have the relative proportions of a single glycan or two glycan structure, depending if the structures co-elute or not. And we also have a MS-based approach. So you would have your glycoprotein, you would treat it with trypsin, you would get glycopeptides, and then you would chromatographically separate your glycopeptides and then run them on the MS to get their exact masses. And then again, you would similarly, as in the chromatographic approaches, relatively quantify them. So we get a relative quantification of our glycans. So we do not have absolute numbers, but the relative, they're normalized to the total chromatogram area. Okay, can I supplement sialic acid precursor to assist my cells in production of sialylated glycans? So this MANAC is actually, I think it's in a clinical trial for several diseases which are characterized with low sialylation. And I think these clinical trials are run by the NIH, American NIH, and it's still work in progress. But it's a simple sugar molecule, and I think it's so far treated as the dietary supplement. So in theory, it should work. If your sialic acid levels are low, you could supplement your cells to produce more sialylated proteins. But as I've said, there's a trial ongoing, so I hope we'll know more in the next couple of years. Okay.
Thank you very much, Tamara. Does anyone have any other questions? Thank you. Thank you, everyone, for joining us today. If you have any other questions later on, you feel free to send them through to us